So we are so excited to be here to chat with you all about this research project that we've been doing, really focusing on self-care and burnout prevention strategies. Specifically, we were working with folks who were peer support workers for substance use disorders, but a lot of these strategies would work for folks kind of across different peer settings. So my name's Sarah Miller. I am a doctoral student in psychology. My research focuses on really thinking about psychosocial supports for folks with vulnerable diseases. So thinking about HIV or opioid use disorders. And I also work clinically with folks with opioid use disorders. I'll let my co-presenters, Maggie and Sayward Harrison, introduce themselves as well. Maggie, do you want to go first?
Sure. Hi, I'm Maggie. I'm a third year, finishing up my third year in my doctoral program here at University of South Carolina. My research interests focus a lot on youth-led efforts to address mental health stigma and prevention. However, clinically, I do work with a lot of folks with substance use disorders. So excited to be here today.
Yeah, and same for me. Hi, everyone. My name is Dr. Sayward Harrison. I am an assistant professor at the University of South Carolina in the Department of Psychology. I'm a health psychologist, and I really focus on how we can better support people who are living with stigma healthcare conditions. So most of my work is in the area of HIV interventions, both prevention, treatment, care. Peer support workers have been critical in our efforts to improve outcomes for people living with HIV here in the US and across the globe. And more recently, I've shifted into doing more work around the opioid epidemic here in the US. And that's going to be the root of what we're about today. So it's great to be here. Thank you.
Before we get started, we just want to acknowledge our co-authors who are fellow students with us at the University of South Carolina, Ellie Wu, Sarah Grace Ferry, Elizabeth Podolsky, and Wendy Chu. And they all contributed significantly to this research, but were unable to come today due to some schedule conflicts. We don't have any conflicts of interest to disclose today. Just to give you a little bit of an agenda for where we're going to go today. First, we're going to tell you a little bit more about our current work and how we got into this field, a little bit about a center that we just started focusing on substance use. We'll give you some background on substance use disorders and kind of how we got to the current study. And then we're going to spend the bulk of our time really digging into self-care and burnout prevention strategies, hopefully for you to be able to take some of those home with you and use them. And then we're going to save some time for question and answers at the end. But feel free as we're talking to pop questions into the chat box as well. Before we get started, we do want to get a sense of the room. So if you can put in the chat box what your current role is, so whether you're a peer or a researcher or an organizer, what general populations you're working with, and then just, what brought you to this session today? What is your goals? What do you want to get out of this session? And we'll give you a minute to type that up and put it in the chat box so we can get a sense of what everyone is coming to with today. I just realized I can't actually see the chat box, but that is okay.
We've got people commenting, working for different CRSS programs, working in a CRE, running peer training programs out in the community, some people who are involved in work through CC. So lots of exciting, behavioral health specialist, lots of kindred spirits with us today.
Yeah. Well, that's great. So excited for all of you to be here. So with that background, I'm going to turn things over to Sayward to talk a little bit about our setting.
Sure. So at the University of South Carolina, we have been really fortunate to recently receive a training grant from HRSA, Health Resources and Services Administration. So I wanted to share a little bit about the background and how we're moving into this work. So recently, HRSA has identified that we're facing a critical shortage nationwide in terms of the numbers of psychologists, mental health professionals who are receiving training to be able to come out and go into the field and work in substance use disorder prevention and treatment. So I'm going to talk in a few minutes about the history of the opioid epidemic here in the US, but probably each of you are really familiar with this idea that we're really in a crisis around opioid dependence, opioid misuse, opioid use disorder here in the US. Opioid epidemic has shifted over time, but is really impacting every community. And probably if I asked for the people who are on this call today, every one of us could say someone we've been impacted by an overdose death or by just more broadly a substance use disorder, whether that's you, someone in your family, someone who you work with, a community member, who you've seen go through this struggle, dependence. So HRSA has identified that in order for us to really address this as a country, we need more mental health professionals to come out of their training program ready and able to partner in efforts to respond to the opioid crisis. So we received funds to start a training center at USC called the Supporting Substance Use Disorder Services in South Carolina Center. I'm the director of the center and have some fantastic other faculty who are involved. And you can turn the slide, Sarah. And the long goal of our is to really address this critical shortage of there not being enough psychologists who are currently working in substance use disorder prevention and treatment. And to also think about how we can improve our statewide outcomes here in South Carolina related to opioid dependence and other substance use disorders. So the goal of our new center here is to provide high quality training for our doctoral psychology students so they can both get the knowledge, but also those practical clinical skills so that they can partner with other people, including peer support specialists, in addressing opioid dependence in our communities. Our goals are also to just increase the number of PhD level psychologists. So here in South Carolina, we experience tremendous shortages of really all healthcare and mental health professionals. Out of all 50 states, we're 50th in the country for the number of psychologists per resident. So we're dead last. We have very, very few psychologists. Only one APA accredited training program in the whole state, and that's ours. So we really realized that we were not doing enough to equip our students to engage in prevention and treatment of substance use disorder, including opioid use disorder. And now we're really intensifying our efforts to build up more transdisciplinary research, to contribute to improve our policies statewide too, of responding to the opioid crisis. So we've developed a fellowship, and our fellows are actually the ones who this research project that we're going to talk about today. But we've developed a fellowship here at USC where we give our doctoral trainees in psychology didactic training. They're taking coursework in responding to the opioid epidemic and evidence-based prevention and treatment strategies. And then they're also placed out into clinical externships in community-based settings, in hospital settings, and primary care settings, where they're doing hands-on work in integrated care for individuals with opioid use disorder and other substance use disorders. All right, so I wanted to just talk for a minute about the current state of the U.S. opioid crisis. So, so we know that opioids they've been around, and humans have been engaging with them for as long as humans have been around. Our bodies are built with receptors that were to opioids, and opioids are naturally occurring in our environment through the poppy seed. So you can think about historically, you might have heard about opium dens, or seeing people smoking, or learned about how people used to inject morphine. All of those are different historical ways that humans were consuming opioids. What's happened recently is that shifts in the the formulation of those opioids, and then more widespread access has really created a crisis here in the U.S. So this current crisis can be dated back to the 90s. I don't know if people have read or watched Dope Sick. There's a number of fantastic books out there. The least of these, Dreamland, that detail these different stages of the U.S. opioid epidemic, and a number of them are now being turned into really compelling programs on Netflix, on Hulu. So I would recommend watching these to get a good sense of the background of this crisis we're in. But from the mid 90s to the mid like 2014, there was a lot of overprescription of OxyContin by healthcare providers here in the US. And this was really driven by a very kind of systemic issues in our healthcare system. There was new medicines that were available that did a really effective job reducing people's pain. So people who were in pain wanted them, it made them feel better. Doctors and other prescribers were being encouraged to get those pain levels down. Pain was added as what's called the fifth vital sign, where every time you went into the doctor's office, now suddenly you were being asked, do you feel any pain? Oh, we've got something that can help reduce that pain. So in this very short period of time, OxyContin began to be widely prescribed, which created base in our country ever of opioid dependent individuals, because what we know about opioids are they're highly dependent because they're so good at producing things of euphoria and pain relief in humans. And the second this crisis, we began as a healthcare system to pull back on that overprescription, but people were still really dependent. So as suddenly it became more and more difficult to get OxyContin and more expensive to get those prescriptions filled, many people who were now dependent on these medicines began turning to opioids that they could get off of the street, often more easily and more cheaply than going in and getting prescriptions for them. So in the early 2000s to around 2017, suddenly now there was a shift to using heroin, right? A shift for people who were dependent on OxyContin to shifting to heroin use. And at this time, that the supply of opioids in the US really shifted from healthcare providers to Mexican trafficking groups who were bringing heroin over the border and then delivering it to individuals in the US who were dependent. So we saw heroin-related emergency room visits skyrocket, overdoses began to increase, and the opium poppy agriculture was really what was driving that. But we're now in a whole new where suddenly there were advances in how people could produce synthetic opioids, so often relying on bringing in chemicals from and kind of backroom production through pill presses and counterfeit pill manufacturing. Now we've seen that what people are consuming for opioids is typically fentanyl. So heroin has dropped steadily and been replaced by fentanyl use in the US. And this is creating a real crisis. You can continue. So what we know is that nationally, when we look at drug-involved overdose deaths, we've seen an absolute skyrocket over these years. In phase 1, there were overdose deaths from prescription opioids, and you can see on that grayish line, these really kind of steadily rose over time. Sarah, you can go to the next slide. Then in phase 2, where we see this shift to heroin, that's that black line, we see increase in heroin-involved deaths. And then now in phase 3, we see just an almost vertical line of fentanyl-involved overdose deaths. And these are what we call these synthetic or these human-produced opioids that we have. When we think about fentanyl, so South Carolina, fentanyl is now involved in about 4 out of 5 overdose-related deaths. Fentanyl-involved overdose deaths have increased over 400% in our state in these last few years. And what happens is that fentanyl is just much more potent than heroin. So individuals who maybe used to use heroin and are now consuming counterfeit pills, that the amount that they're getting is just massively increases their dependence on that substance and creates a real risk for overdose deaths. So fentanyl is 50 times more potent than heroin. And again, it's just rapidly replaced all the other opioid drugs in our US supply. And you can go forward now, Sarah. So when we think about dependence, whether it's on opioids or on alcohol or a different drug, when we're thinking about substance use disorder, we're really focusing on 4 key criteria. Impaired control, that individuals begin needing to use the substance more often, longer periods of time, and they're not able to control their use as they once were. Therefore, they're spending much more of their time seeking out that substance, consuming that substance, and recovering from those bouts of use. So it's beginning to eat up lots and lots more of their time. So this links to that social impairment, because so much of one's time is now spent consuming, using, and recovering from this substance. A person begins to have difficulty fulfilling other roles in their life, whether it's fulfilling their roles within their family, within their relationships, at school, at their work. We also see risky use, right? So an individual may be continuing to use even though there are risks to their health, risks to their mental health, risks to their relationship. They might be seeking that drug and using that drug in hazardous environments, but that dependence, that physical dependence, is so strong that they're not able to stop or resist, even though they may recognize and be well aware of this risk. And then we're going to talk too about pharmacological criteria. Thank you, Sarah. Which is really that the body is changing in the response to the substance use. So when we think about diagnosing substance use disorder, the recommendation is to use the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. And this is used to diagnose substance use disorder across a spectrum. So depending on the number of symptoms an individual exhibits, they may have mild, moderate, or severe substance use disorder. And it's really important to know that substance use disorder and other mental health disorders often co-occur. It's really common for individuals who are experiencing, whether it's depression, anxiety, post-traumatic stress disorder, or other mental health disorders, to have a co-occurring substance use problem. So it's important for individuals to both receive assessment for substance use disorder as well as any other potential mental health disorder. You can turn it, Sarah. Thank you. And so here we just see, what it looks like when we look into the DSM and what some of those symptoms are. So when we think about substance use disorder, again, we've got that first impaired control over substances, consuming in larger amounts and for longer time. An individual might feel like and know they need to cut back, but they're not able to regulate their use. They might have had many attempts to cut back, but those are not successful. And really, we think about that craving, that drive, that again leads to those sermons that I discussed, those risky use experiences. Now, I wanted to spend a moment or two talking about pharmacologic criteria. So when we think about, substance use disorder, it's really important to understand addiction, or we could also say dependence, as being a chronic disease in which areas of our brain that are responsible for our reward systems, for our motion, even for memory, they become changed and they become dysfunctional, right? So brain impairment is really what underlies substance use disorder or dependence on these different substances. And we see that because we see these pharmacologic changes. So tolerance. So individuals with substance use disorder begin to need higher and higher doses of that substance to achieve that same high feeling, that same, whether it's euphoria or that same reduction of pain that they initially achieved, which with much amounts of that substance. So we see a physiological dependence grow within the brain of an individual. We see symptoms of withdrawal. So if an individual is not consuming that substance, they begin to show signs and symptoms because blood and tissue levels of that substance decrease, and the body doesn't like it. Now the body has developed this real need to keep levels. So when they're not there, an individual experiences what we call, dope sickness, really, really strong, terrible physical symptoms that make them just feel yucky. And again, kind of serve to reinforce that use, because then when they use again, those terrible symptoms go away. And that's why it's also so important to understand what our current treatments are. Use disorder, in particular, opioid use disorder. So our gold standard for opioid dependence is medication-assisted treatment. So when an individual is able to receive a medication that can help reduce those cravings and help blunt that high that those opioids would typically give. So those medications in the US that are available include ones you might have heard of before, like methadone, buprenorphine, Suboxone, and naltrexone. And what these medications do is they normalize the person's brain chemistry who has become so dependent on opioids. They help reduce the cravings for those opioids, and they normalize the body's function so that the person doesn't have to go through those painful opioid withdrawal symptoms as they slowly wean off of their dependence. These also help for individuals who are dependent or addicted to opioids by blocking the euphoric effects, right? So beginning to kind of break that, that association between the drugs and that high, good feeling for the individual. So these are really life-saving tools. So individuals who are misusing opioids, who are dependent on opioids, really need to get in to see a healthcare provider who can, with medication treatment. Okay, so now that we've talked a little bit about the background of the opioid crisis in the US, we're going to shift and talk about a new project where our fellows have been working with peer support workers.
Thanks, Sayward. So I'm not going to talk too much about peer support workers since some of y'all are probably familiar with it. But we just wanted to highlight kind of like this central and key role to recovery, right? So peer support workers fill in a lot of gaps, providing necessary resources to individuals who are entering recovery or in recovery, and fill some needs that clinicians often cannot provide. So the extra social support, shared lived experiences, and peer support workers have often been associated with better outcomes for folks in recovery. Next slide, Sarah. So a little bit of background about our study. Just briefly, I want to highlight kind of what inspired us to really engage with peer support workers so through our fellowship, we had the privilege of going up to Greenville, which has our kind of big healthcare system here is Prisma. They have a very big substance use disorder center up there. We got to meet some folks, see the work they were doing with capacity building and just the overall structure that they had. And we got to meet some peer support workers who were working in their system. And we were just very struck and inspired by the way these folks were describing their experiences working with their participants and clients, having that lived experience, filling those gaps. And we really thought about is, what does support look like for peer support workers when you have those lived experiences and you're working with folks in your community? What does support, self-care, and mental health look like for a peer support worker? So really our aims were to just broadly understand the experiences of peer support workers. For substance use disorder specifically, we realized there's not a lot of research out there right now that touches on peer support workers and how that impacts their mental health. And then we really wanted to identify burnout prevention and self-care strategies that are used by peer support workers, and then identify additional ways that organizations can better support burnout and self-care for their peer support workers. And then so for this portion of the project, we're just going to be focusing on those burnout prevention self-care strategies. This was a very big mixed method study that we did. We sent out surveys, asked many questions, but for the purpose of this, we really wanted to focus on burnout prevention. And our main goal today is for you to walk away with some tangible ideas on how you can engage in self-care or potential ways that you can support peer support workers at your own work. So for a specific study, we interviewed and sent surveys to 25 peer support workers for substance use disorders in South Carolina. They all had been peer support workers for at least 3 months. Our interview guide, we had a cool opportunity to kind of involve a peer support specialist. So they got to provide feedback on our questions, ensure that what we were asking was kind of representative of peer support workers' experiences. Then, of course, we transcribed our interviews, and we were trained in rapid qualitative analysis, which is kind of like a quick way of scanning our transcripts for common themes and pulling those out to really make some of the quotes that we're going to talk about later. So just a little bit of background on our participants. As I mentioned, all of our participants were peer support workers who were in the job for at least 3 months. We had a wide array of identities, so pretty diverse with gender, mainly white participants, and then a wide array of levels of education, and then full-time, part-time employees, as well as volunteer peer support workers. A little bit more about our participants. So our average age was around 49 years old. Thinking about how many years they were in recovery, average was around 3 years working in peer support. So we had a wide range of how long folks have been working in their role, and our average was around 12 years. A big key piece here, as I'm sure some of you peer support workers know, is the hours of training, which is something we're interested in. Of course, there's like a lot of training, continuing education, but our average here for our participants was about 112 hours of training. And then just to think about how many folks they're serving in their role within the past month and lifetime, we can see in the past month, our participants were interacting with, on average, 38 people in their community. And then over the course of their lifetime, over 841 as an average of folks they're interacting with.
All right, so we're going to shift gears to thinking about some of these specific self-care strategies that folks were using. But before we do that, I want to frame our conversation as to why self-care is really considered to be important. So go ahead and jot down some ideas of why you think self-care might be important. Why are you here? Sayward, I'll have you kind of shout out some of the main findings that you're seeing in the chat box as folks are putting them in.
Sure. Okay, well, I put the first one in. So to help prevent burnout, especially when you're in this really high stress role. Any other ideas about why self-care is really needed, or why it's something that we should focus more on for peer support workers? I can speak a little bit from my past role as a practicing psychologist. That again, these are really high stress positions. When you're caring for other people all the time, I think it can be easy to forget to care for yourself, and then your own mental health or physical health suffers.
Mm-hmm. And some of our participants in our study kind of touched on this with some analogies that I found really helpful. And you'll see on these slides, there are names. These names have been de-identified. So they're not folks' actual names, but we found it helpful to kind of identify who they are. So one person said, if you water the root of the tree, the whole tree is taken care of. But if you forget the root and care only for the branches, you can't keep the tree alive, right? So burnout, if I'm trying to take care of the patients and I'm not taking care of me, it's all going to fall apart. Another person talked about keeping their cup full to take care of others' cups. And then one other individual shared a quote that I found really insightful of, you could work 24/7 trying to help people and not make a dent, in the problem. So you really do have to set boundaries and do that self-care for yourself, or you could burn out very easily. In order to have longevity in the field, you really do have to take care of yourself every day. And I think these really just highlight the importance of making sure that we're taking care of ourselves, not only for ourselves, but also, for those folks that we're serving, so that we're able to keep going.
Yeah, and I'll just add in, Sarah, from the chat. Thanks so much to people who are participating on the chat too. People have said, it just is really necessary to maintain our own stability in these roles, to manage the stress, to help us do the best we can do, giving our services to others. And also, I loved this one, to continue to heal. So especially as in our work with peer support workers who are working in substance use disorder prevention. So these are recovery coaches who are in recovery themselves. That what you just shared there in the chat, I think McCormick, is really powerful. Like, we're also often healing from our own past traumas or experiences while trying to do this role and help others, which makes self-care just critical. Thanks.
Thank you all for participating and for sharing your thoughts. So we're going to talk through some of the specific burnout prevention and self-care strategies that folks were using, who we talked with. And just to kind of frame this conversation, we're going to be going through a lot of different self-care strategies. And hopefully some of these will be useful for you, but I think it's the key thing that we saw through the interviews was everyone had different strategies that worked for them. And so we wouldn't expect any individual person to engage in all of these strategies, but really to pick the ones that work for you. And we'll walk through each of those. So the first main theme that we saw was kind of setting up work-related self-care. And the first thing that participants really talked about was boundaries that they set with work. And pretty much everyone in our study really identified having good boundaries between work and home life was really important for maintaining their own mental health, their own recovery, as well as preventing burnout. But how people did that did change based on the individual. So there's 3 quotes on the screen. One individual talked about how, he told his clients they could call him 24/7. But that doesn't mean he answers his phone 24/7. And so he said, you can call, but if my phone's off, I'll call you back. And that was his way of being a resource to folks, and letting them know they can call him, but making sure to be able to have time that, he was off the clock. Another person, Todd, talked about how when he had seen his friends hit points of burnout, them saying, I don't have bandwidth for this anymore. Someone else needs to work on this. Someone else, Tinkerbell, talked about how her boss was always working in the evenings and sending her emails in the evenings, but she said, nope, at 5 o'clock, I'm done. I'm not going to check the email. I'm not going to respond to that email after those hours. Other folks talked about how important it was for them to clock in and clock out at the right times, or having other types of boundaries where they said, this is my hard line. That's not what I'm going to cross. And these were different for different folks, but the common theme was having those boundaries that they established. We also found folks talking about kind of really thinking about their mindset when it comes to their work. A lot of folks talked about how it can be really difficult to be pouring into individuals who, are not in recovery yet and helping them to get to recovery. And they talked about how they really needed to kind of have some distance of that. So recognizing what their role was, that they can't save every person, and that it really is up to the individual whether they enter into recovery or not. So folks shared about how, they couldn't want other people's recovery more than they did. Another individual talked about how she reminded herself, what, at the end of the day, I'm getting my paycheck, whether or not folks are sober or not. And I think all of these really go to highlight the impact that this kind of mindset shift can have of thinking about what is my actual role and not holding myself accountable for things that are beyond my control. Other things that folks really talked about was taking time away. So this encompassed lots of different areas, from I'm going to take time off, go on a vacation, go to the beach, go to the mountains, have time that's my time to relax, to even little things like I'm going to take 10 minutes in the middle of my day to take care of me and respond to texts that I get, or to really unplug from everything in the midst of my day and take that time off. A really important theme that we saw in terms of what people shared was thinking about mental health days and destigmatizing those, recognizing that, you know, a mental health day is a sick day and it's something that is really needed for these individuals. And they really focused on that. And so really what we were seeing here is the importance of, you know, having that time off, whatever that looks like, whatever is restorative for you, but recognizing that work was better after having that time off. Another work-related self-care that folks talked about was how supportive supervision was for them. So people really identified a burnout prevention strategy was having a supervisor who is qualified and could speak to like the clinical aspects of things. And then having supervision regularly when you know it's going to come up so that you can have those questions answered, you can get those supports, especially with those tricky cases that some folks have. Others also mentioned, you know, the value of having peers that they could go to. So other peer support specialists that they could talk with about their work and who also have that shared experience of being in recovery and helping others in recovery and the importance of that. We also saw some self-care strategies related to recovery. So for these peer support specialists, all of them are in recovery themselves. And so a big way that they were taking care of themselves was to take care of their own recovery. For a lot of them, that meant going to self-help meetings, so like 12-step meetings, AA, NA, or even just reaching out to other peers in recovery to make sure that they were getting the resources that they needed. And a lot of them also talked about how valuable it was that resources were available both virtually and in person, so that they had that flexibility. The next theme that we really saw was thinking about one's physical health. And this really spans across lots of different avenues. So it came from exercising and valuing your physical body to eating the right foods, sleeping well, visiting the doctor, taking medications that you're supposed to take, but then also things like pampering yourself. So people talked about going to the spa, getting a massage, having supplies for a bubble bath at home after a stressful day, getting your nails done, making sure to go to that hair appointment, and taking care of all those physical aspects of yourself that help you to feel better about yourself. And then we also saw people talking about really their mental health and the importance of taking care of themselves. A key theme that people mentioned was mindfulness. So a lot of them talked about using mindfulness apps on their phone that they found where they would play a recording and listen to the mindfulness. Others just talked about meditating in their day. One individual talked about how he adapted meditation to really fit with his schedule. So he had a long commute to work, and he said, that's my time to meditate. I take that half hour to meditate and take care of myself. A lot of other folks talked about having their own therapist and how crucial that was for them to be taking care of themselves by, you know, as Sayward mentioned earlier, like dealing with their own trauma and taking care of their own mental health being really important, especially given the difficult work that they were engaging in. And another key theme that folks mentioned was seeing a psychiatrist, taking their antidepressant or other mental health medications as really crucial for supporting their work as peer support workers.
Thanks, Sarah. So next I want to highlight family, which was something that was talked about a lot as a huge role in self-care for our peer support workers. Specifically here, folks talked about engaging in fun activities with their kids, like attending lacrosse games, playing with their kids, hide and seek, just having these little fun and casual activities with family members, like their own children, siblings, and spouses, was something many peer support workers talked about as being restorative and really supported their mental health. Next is hobbies. So again, many of our peer support workers talked about hobbies, so interests that they loved and just connected with. Obviously, they differed from person to person, but there were so many interests that ranged from cooking to puzzles, sports, even just cleaning the house, crafts. One of our participants, Lauren here, talked about that, making sure that she has a hobby as something else to do. It's something just to soak up and find positive outlets outside of work. So hobbies is something many of our peer support workers mentioned engaging in for self-care. Next is spirituality. So a couple of our peer support workers mentioned this role of spirituality as a very important way of coping, avoiding burnout, connecting with kind of this higher being and role for their life. So whether folks went to church, just thinking about faith. Tinkerbell here highlights that they're not typically a person that goes to church, but the first thing they do when they wake up in the morning is read through meditations, connect to this higher universe and this higher power, really just to center and ground themselves. And Lauren also mentions that here. I'm sure some of y'all are potentially familiar with compassion fatigue, but just the potential negative impacts of the trauma you might witness and the work that you're doing, being able to connect with faith was something that was grounding for our peer support workers. And then finally, we want to switch some gears and talk about specific workplace support. So a lot of our peer support workers identified the really great things that their organizations and agencies are doing to support them in their role. And some of these could potentially be used to think about, generally, how can we support peer workers in their efforts to engage in self-care and avoid burnout, whether in the workplace, but also outside of the workplace. We have some quotes here where Todd talks about the clinical world, sometimes not being able to have a voice, to be able to voice the actual core value of a peer worker holds, and really experience. So he saw peers getting substituted for other areas of work. Usually they're more than their menial job, so maybe having to take on extra roles. Educating from the top at each, because oftentimes maybe folks who are higher up, like in administrative roles, don't actually know what peer support workers are intended for and are not really clear what the role is there. Next, we have April, who talked about believing that substance use peers and mental health peers, there ought to be a pay parity. So of course, some organizations offered health insurance, but April wanted to talk about, Medicaid, manual goes, talked about billable pieces, but there was this notion of parity for pay that was critical in thinking about ways to support their self-care. One of our participants, Pouch, talked a lot about directors and supervisors at work and just their overall attitude, work ethic, and relationship that they had. And this was a quite positive note here that Pouch was touching on directors kind of fussing at them when they're working too much or working overtime, and not really making comments that they're not working enough, right? So really focusing on having that balance between how many hours are you working, really just working with Pouch to make sure that his role was realistic and he had the capacity to complete his responsibilities. So just a final note about workplace support is really just for admin and at that organization level, really thinking about different policies and procedures that could potentially be in place to protect peer support workers in their time and ensure that they're fulfilling the role that they were, hired for. And then finally, we want to touch on individualizing self-care, and Sarah mentioned this before, but of course, self-care looks different for different folks. And a lot of our peer support workers comment on this. So Cassidy here, talks about that self-care is not just essentially there's no one definition of self-care for folks. It looks different for people and their needs and the different roles that they're thinking of. It's kind of a big take-home message that we're hoping to center here is we've got a lot of self-care strategies. There's so many different domains from family to work-related self-care, hobbies. And of course, each one may work for some and may not work for others. And it's really important for us and especially peer support workers to think about developing a way that's fits best for them and taking care of themselves, whatever that looks like.
So I think, thinking about all of those amazing quotes from our peer support workers who took part in this study, to sum up, certainly those findings speak to the fact that peer support workers fill really unique roles that can be highly stressful, that sometimes there's a lack of clarity from others about what their particular role and their training and their deep expertise is, and that can play a part in their own experience and their own stress level and the burdens of being in this position. We heard from our participants that attending to those self-care needs is critical to reduce burnout, to reduce their to help make sure that they're able to provide those services to their own clients and make sure that service delivery remains, high quality. And for us, the next steps for us are really thinking about how we as psychologists and future psychologists can help play a part in supporting those unique needs that are experienced by the peer support workforce. So, as you probably, when you think about psychologists, you think about maybe individual and group therapy. And those are certainly things that stand out to me as a role that we as psychologists can meeting needs within the workforce. And we heard many of our participants, talk about the importance of attending to their own mental health needs, whether that's prevention or whether that's treatment focused. We also saw other opportunities for psychologists to become engaged in this work. So we do a lot of work within our department around mindfulness and meditation practices. Those would be potential areas that we're interested in partnering with organizations to see, can we deliver these types of services to your peer support workers? We're trained in different relaxation methods, such as deep breathing, diaphragmatic breathing, other strategies that can help us to really, relax our mind and relax our physical body as well. And then finally, psychologists, maybe you don't think about it as much, but psychologists, especially within our department, which has a clinical community focus, get a lot of training on how we can go in and serve as consultants to organizations or to healthcare and hospital systems to help figure out how can you do a better job supporting those needs for these critical staff members. So another area that we're thinking about in terms of the training of our students is how can we make sure that they're trained to be able to provide that consultation. So as we heard from our peer support workers in this project, the systems, the supports that are available at their workplace, what's being provided to them in supervision, how their boss is treating them and supporting their own mental health needs are really, really important for maintaining good mental health for our workforce. And I think Sarah's going to wrap us up with one final activity.
So as we spent a lot of time today talking about all these different self-care strategies. And I know for myself, when I hear all of these things kind of stated out loud, it can be overwhelming. And sometimes I'll feel like I need to do everything at once. But we thought it would be useful to just take a minute to think about, what's one self-care strategy that you can do for yourself today? Right? It doesn't have to be something that you're doing every day, but what's one thing that you can do today to take care of yourself? And go ahead and put those in the chat box. And I'd love to hear all the ideas that folks come up with.
Okay, I can read out some of these. I love some of these strategies. So we've got someone who's going to treat themselves to a pedicure. I loved those comments from our participants about just the need to pamper yourself, right? To take care of yourself, given all this surrender. Someone's going to go outside on this cloudy day and do some grounding exercises. I love that. If you all are not familiar with grounding exercises, just do a quick Google, and really helpful and easy to learn how to do. Working on remaining calm. Someone mentioned doing a body scanning practice, really checking in with the different areas of your body to identify areas where you might be holding on to that tension. Going outside and getting some vitamin D. Going to be able to see the northern lights in the sky. So having those moments to connect with nature, amazing. Massage, taking the stairs, staying moving, staying active, chair yoga. I mentioned I'm going to finally download Headspace, which a number of people have recommended to me because they've got some great meditation and mindfulness, quick activities on that app. Taking time to connect with a friend. So I love to hear it. And now it's just us holding ourselves accountable and making sure that we take the time, because we're worth it, to go out there and do those things that we've just identified. So amazing. Great work, everybody.
So excited for us all to engage in those. On the screen is Dr. Harrison's contact information if you'd like to collaborate with us or have any further questions. But at this point, we'd love to open it up with our last remaining minutes to kind of hear from all of you if you have questions or other strategies you use to engage in self-care that you'd like to share with others.
Yeah, or if there were any surprising findings or anything you've heard about that's really effective and helpful that we didn't mention, that might be something for us to consider.
I just have a quick question. I know that you mentioned in the beginning that you guys are like, I think you said the 50th state or 51st state that you guys don't have a lot of mental health.
Yeah.
Basically. Sorry, you can correct me if I'm wrong, but it was along those lines. And I just wanted to know if there's anything that you guys are doing to kind of like revamp that in your state in South Carolina.
Yeah, it's a great question. So I think, one part of that is just trying to figure out how to make mental health services more easily available, since there is such a lack of them in our communities. And, I'll say that we have developed over time a psychological services center where Maggie and Sarah work. And so we place our students in that center, and they can offer either free or very low cost services to our community. It's a great way that we can help to meet some of those unmet needs, as well as get our students just excellent training opportunities. So we have developed this large, our PSC, we call it, which is kind of our clinic. And I think more broadly, we're very interested in looking at training more master's level clinicians. I'd say historically in psychology, our association APA only accredits at the PhD level. And I think that's a real problem, because that just means that we don't have many people who are training at the master's level and then going out in the community to provide mental health care. So we are in talks. APA is actually going to change that over these next couple of years and begin accrediting at the master's level. So I think broadly, like nationwide, that's going to be really important to just increase of mental health providers that are out there. And I don't know if Sarah or Maggie have other thoughts about other ways you've seen us trying to meet those needs here in South Carolina. Cassidy, I see you raising your hand.
Yes, I had a question. In the presentation, you mentioned how it's important to have a supervisor. What would you recommend for our leadership team, right, that don't really have a supervisor? They are the supervisor. Have you worked in that? What have you seen?
Yeah, that's a great question. So one of our participants actually talked about this, where she was a supervisor and was like, I don't like, I'm at the top. Who do I go to? And some strategies that she used is reaching out to supervisors at other organizations, kind of across the state, and asking them for consultation, right? So when she hit a point where she didn't know what to do, like to ask for a consultation. Another really cool thing that exists in our state, that I think if it doesn't exist where you are, it would be awesome to create, is we have a group called Peers for Peers. Which is a group that meets virtually every Friday night, and they're all peer support specialists. And it's a support group for them. And so they'll have different speakers come in on different topics. But then other times they just have case discussions, where, someone shares, this is what's going on. I want to hear your thoughts. And a lot of folks who, kind of were at that upper level, they were supervisors, found that really helpful, as well as in South Carolina, we're a pretty rural state. And so there's some folks who they were the only peer support really working for their organization. And so they found that helpful to be able to get that connection with other peer supports when they didn't have necessarily that supervision available to them internally within their organization. Did that answer your question?
Yes, thank you.